I'm presenting a case of non-linear behavior. Yes, my slide. Yeah, this was the compound fracture, lower end, both bone leg. डॉक्टर शमशेर स्लाइड चलेंगी कहाँ से? हाँ, yeah.
We have to say next.
This, yeah, next is 32 years male, had roadside accident with fracture both bone. Next, the external fixator was applied and negative suction dressing was done. Next, the skin grafting was done, wound was covered. Next, now the real challenge is this is external fixator, is a gap non-union, and there is a back of bone in the lower end of the on that lower 1/4 of the tibia. And the most common complication, infection, skin loss, shortening, back of bone, and instability is there. Next. So what is the basic requirement of fracture healing? Stability of bony fragment, number 1. Number 2, optimally preserve blood supply. Number 3, biological or hormonal stimuli in order to unite. This is very important, and corticotomy does this. Number 4 is preservation of limb function. Next. So this is AP and the lateral view. This is a non-union, infected non-union. Then what you will do next? Shamsur, next. Yes, how it is planned. This is back. Shamsur, back. This is our planning. This is a lower 1/4, the tibia is bone loss. So we plan corticotomy in the upper end and the compression or docking at the lower end. So these planned it. Next. So what are the basic principles of Elizaro or dissection osteogenesis? Next. The law of Julius Walls, when any bone is subjected to compressive force, is start consolidating to a stronger bone. Next. Another principle is accordion maneuver. An alternate cycle of dissection compression at delayed or non-union site will trigger bone regeneration. These are 3 principles for Elizaro. Next. We simply apply 4-ring Elizaro. Next. As usual, we dissect the first and second ring corticotomy and the compression at the fracture site. Next. Dissection at 1 millimeter per day. Next. Next. This is post-op X-ray. The corticotomy is done at the upper part, and there is decreasing the gap in the lower part. Next. This is dissection of the corticotomy. Next. This is dissection, and there is no gap between the bone ends. The bone ends is approximated, but there is no sign of union at the docking site. Next. So what to do? Third method is accordion method. We compress on the docking side, then we dissect at the compression at the lower end fracture ends. Then start the process of callus formation. Next. This is the callus is formed. The Elizaro was removed and protected in the plaster cast. This fracture union was achieved. Next. This is complete union is achieved. Next. Next. This, yeah, from here to the union site. This is the magic of Elizaro. The simple principle of compression and dissection at the non-union site will trigger the union. So the beautiful results. Next. This is clinical result. Next. Next, clinical full function of ankle joint. Next. This is pre-op, then after the finishing of the result. Such a simply done technique of Elizaro. Next. The Elizaro provide relative stability with minimum damage to the soft tissue and dissection disturbance with the blood supply of the bone. Next. It is very simple, easy, and minimally invasive stabilization of the bone. Next. When all else fail, think of Elizaro external fixator. Next. All complicated cases are very well treated by simple Elizaro, 4-ring Elizaro, 5-ring Elizaro. Next. This is salute to the Elizaro. Such a difficult deformity is corrected very well. Next. Thank you. One more case. Dr. Shamsul, next case. Yes, most commonly we will find these type of cases in our wards. The one side amputation was done and the fixator was applied on the next side. Next. Pre-op X-ray, infection with deformity with alignment. Next. Same debridement was done. There is no callous sign of union anything. Next. Next. Same after removal of fixator. Then we planned for Elizaro. 5-ring applied. Corticotomy done in the upper ends of the tibia. And the compression after debridement, the compression at the fracture side was done. Next. Same EP and lateral view. Next. There is a approximation of fracture side and opening of the corticotomy. Next. Same. Next. This is corticotomy is opening up. I took a fibular graft in between the fracture fragment. I do the mistake. Never do this. Next. Next. Corticotomy is opening up. Fracture is. This is corticotomy is opening up, but there is no sign of union at the fracture side. Next. Next, the corticotomy start uniting, but fracture is not uniting. Then we again do the dissection at the fracture side after compression. That shown again shows the signs of union. Next. Next. Yes, this is a non-union at this is hypertrophic non-union at the site of the fracture. Next. Accordion maneuver, there is start uniting after accordion maneuver, dissection and compression alternate. Next. Next, corticotomy united, fracture also going to unite. Next. Next, fracture uniting. Next. Yes, this is fracture is uniting, corticotomy is fully consolidated. Next. This is complete union. Next. AP and lateral view, well aligned. Next. This is clinical photograph. Process at one and other leg is fully weight bearing. Next. This is a good result for Elizaro. He is working very well. Next. Thank you.